don't have the facilities to go ahead and treat it properly. So I think with these words, I feel that we should go ahead with the talk without wasting too much of time. Dr. Fabio.
So thanks for all the organizers for inviting me to this, I think is a very, very interesting webinar on a topic that is quite controversial, but where decision making is absolutely crucial, I believe. So my presentation will be essentially on our experience about the national UK program that we put together to help our surgeons and our clinicians in the management of these significant polyp. And I'm pretty sure this will stimulate a quite significant discussion. If I can have my presentation. Can I have my presentation on, please?
I think I need to make you host.
Thanks.
Can you share the presentation?
Here we are. Excellent.
We can see. Good.
So first of all, a quick presentation. So I work in Basingstoke, which is a small and completely unknown town in the south of England, not far from London. But it's very famous among the colorectal surgeons because it's the town where Bill Hild made popular the total mesorectal excision. And when I speak to my students, I always tell them, you know, there is the pre-Bill Hild area where recurrence after rectal cancer was about 30–40%. And there is the post-Bill Hild area where recurrence rate after management of rectal cancer went down to less than 5%. And of course, things have moved on, and now we are seven, actually we are 8 of us. We appointed another consultant, and Brendan Moran, who is my senior colleague, also established a very prominent peritoneal malignancy service. So now, in addition to colorectal surgery, we also deal with patients with the peritoneal malignancy. As you can see, we are a very multicultural, multi-ethnic group. And you wouldn't believe, but out of 8, only 2 are English. And so it's interesting because what is difficult is the management of the extreme. From one end, we have the patient with peritoneal malignancy, which are clearly a challenge, but also the management of the what we call Specc, which stands for significant polyp and early colorectal cancer. Also, the management of these small lesions can be quite a challenge. And so this is the outline of my presentation. So we'll discuss what is a Specc, how are we managing Specc in the UK, what is the Specc national program that we had in the UK a few years ago, and whether we actually can do better for our patients. So we define Specc as a non-pedunculated lesion larger than 20 millimeter, which is technically difficult to remove completely and safely, where malignancy cannot be excluded with certainty. We believe this is a good definition. Clearly, it's not perfect definition, because we all know that sometimes we find cancer even in smaller polyp. And this is what we are talking about. These lesions that, well, they look benign, but they are big. And the question is, am I able to remove these? Plus, sometimes they have an area which doesn't look quite right. So is this a cancer down here where there is this depression? Again, another lesion with a depression area. So this is what I'm talking about. And we know that about 5% of these lesions we know that 5% of the polyp are more than 20 millimeters in size, and about 15% of these, they're actually cancerous. So this is the tricky bit. And the difficulty is always about, should we remove this endoscopically or should we do an operation? But I can tell you it's not as simple as that. So how are we managing Specc currently? Because we didn't know, we put together a multi-center retrospective study, which included 9 centers, has been published 1.5 years ago, more or less, in colorectal disease, where we analyzed 396 more than 2 centimeters significant polyp. The good thing that 85% of these have been actually removed endoscopically. So we were quite pleased to see these results. 6% had surgery, 6% had a transanal excision, and 3% had no treatment, or because patient didn't want treatment, or because patients were unfit. Then we analyzed a minority of patients who went straight to surgery. And we realized that 32% was because the polyp was too large and unsuitable for endoscopic excision. Sometimes they were too close to the ileocecal valve, or difficult to access because at the level of the, a flexure. But in 46%, there was no explanation. It wasn't clear from the letters, from the discussion with patient, why patient was sent for an operation. In this polyp, we found 11% of them were cancer. And this is consistent with the previous findings in the literature. Of these 41 polyp that ended up being a cancer, half of them were biopsied. And we can discuss about the role of biopsy, but all the biopsy came back as benign. So the biopsies were not representative, clearly, or not particularly useful to establish future management. And we know that sometimes the cancer is only in a small part of this polyp. And we know by previous literature that actually when we do a biopsy, we do induce scarring. So we can transform a lesion which is suitable for endoscopic excision to no longer be suitable for endoscopic excision because of our biopsy. So we need to consider a biopsy very carefully. Only 10% of the polyps actually recurred, but the recurrence was always tiny and very quite easy to manage. But a proportion of patients ended up having surgery after the polypectomy. And the main reason why they had surgery is because it's the common scenario. We remove a polyp, there is cancer in the polyp, so we tell the patient, okay, you need surgery. However, 60% of the patient who had surgery because we found a polyp, in the specimen there was nothing. There was nothing in the lumen and the lymph nodes were all clear. So 60% of these patients had unnecessary surgery. So this is something we need to really have in mind when we discuss management of surgery with these patients. And then we wanted to analyze the difference in the management of this polyp between the bowel cancer screening program and the symptomatic patients. And this is quite important because in the UK, the endoscopy would do bowel cancer screening program. They go through a very tough, I would say, a quality assurance process. So they're much more skilled endoscopies compared to the normal endoscopy, the endoscopies that perform colonoscopies to symptomatic patients only. And we found something very interesting, that when patients were managed within the bowel cancer screening program, were more likely to have endoscopic resection of the polyp during the procedure, 65% versus 34, quite drastic difference. Less likely to have a biopsy, 20% versus 48%. Less likely to have surgery, 6% versus 15%. It's almost a factor of 3, and had a much better surveillance. So clearly we found there is a wide variability, and wide variability often means that there is a problem. That's why we decided to put together this national program by a very distinguished faculty, which went all around the country over the course of 2 years to train and educate different MDTs to improve the decision making for these difficult lesions. And it was all organized by the Pelican Center. It was completely free, so nobody had to pay anything. And it was led by Brendan Moran, who is my senior colleague in Basingstoke, who set up our amazing peritoneal malignancy service. And it's all about structuring the management of this lesion, starting with the definition, being able to recognize and assess this lesion properly, documentation. We want the endoscopists to take lots of pictures, sometimes even videos may help. And these need to be discussed in a meeting, what we call strategic planning, if possible, a dedicated Specc MDT or significant polyp MDT to then establish the best treatment for that particular patient. So can we do better? Of course we can do better. We started with this Specc program. In Basingstoke, for example, we started 2 years ago a dedicated Specc MDT, but I'm fully aware it's not possible to start a Specc MDT or a significant polyp MDT everywhere, but we need to be aware about challenges related to this lesion, and then we need to audit our results and do research, because we need to improve clearly results in the future. And when we discuss these lesions in our multidisciplinary team meeting, the questions are always the same. Does this polyp look benign? Does he have malignant figures? Can we remove endoscopically, transanally, or we need to do surgery? Or we discuss histology, the classical example of a small bit of cancer inside the polyp. And is patient fit for surgery? Or does patient want anything done? And this is the form that we use for our Specc MDT, where we essentially analyze and histology investigation, further management, and histology. And clearly, the location of the polyp pose different challenges, because we know from our data that 1 in 3 of these Specc are in the right colon. But removing this lesion from the right colon is a real challenge for our endoscopists. We can see here a large Specc of the cecum. You need somebody really skilled to be able to remove this polyp endoscopically. A third of the Specc are localized in the rectum. And clearly the rectum offers some advantages, because clearly the rectum is completely surrounded by mesorectum. So when we have to remove a significant polyp from the mid-rectum, which is ideal, or the low rectum, clearly this is something can be done easily, not always easily, but can be managed significantly well transanally. Clearly, when there is a polyp in the upper rectum, there may be challenges, particularly when it's located in the upper anterior rectum. So we have more options in the rectum: transanal excision in the form of TEMS, TAMIs, and hopefully in the future we'll have robotic transanal excision, which I'm sure will really help in the management. But there is also radiotherapy or contact radiotherapy, particularly if we have a patient who is particularly unfit. What we do when we have a rectal Specc, we try to assess it properly and leave nothing to chance. The way we do this is by doing what we call a triple assessment. which is a way of assessing this lesion that's been made popular by Neil Borley in Cheltenham in the UK, according to which every time there is a diagnosis of a speck of the rectum, we get the patient in for a flexisymodoscopy, during which you can analyze the polyp properly and suck all the mucus around to have a proper assessment. We do a regisymodoscopy to assess with precision the distance of the polyp from the anal verge, and then we perform an endorectal ultrasound, which we believe being very useful in the assessment of this lesion, because as we know, MRI is not particularly accurate for identifying whether a Specc is benign versus being a T1. But this is an endless discussion whether MRI is better than EUS. As a matter of fact, they are complementary, and both of them should be done when we have a speck of the rectum. And this is the classical case. This is simply a picture I've taken from the Specc MDT of last week. So this is a lady with a 3 by 3 centimeter speck of the low rectum on the right side. It was between 7 o'clock and 10 o'clock. I've done a partial thickness TAMIS, and as you can see, to be honest, my assessment was a very soft polyp, and when I've done endoanal ultrasound, there was no clear evidence of T1 invasion, and the MRI was unconclusive, but has been found a small spot of a T1 invasion that has been classified as SM2 with no negative features and negative margin. So this polyp has been completely excised. There is no cancer at the resection margin. And now the question is what to do. This is the classical, and the answer clearly is not clear, okay? I had a chat with this patient already. I explained that there is a cancer. I explained that the resection margin are completely clear. So we agree that the management for this is active surveillance. What does it mean, active surveillance? It means an MRI every 4 months, flexisymodoscopy every 4 months, for 2 years, a CT scan every year, and a full colonoscopy in 1 year time. So the surveillance is a quite strict surveillance, and this is possible, not suitable everywhere. And this is another case we discussed recently. This lady, which is losing lots of mucus from the back passage and has been admitted because of hypokalemia caused by this massive lateral spreading tumor involving 100% of the circumference of the rectum. Of course, biopsies have been taken, they're all benign. So what to do in this case? Overall, there is a tendency to overtreat this patient, and this is clearly not right. So this is why the decision making is absolutely crucial, to take a balanced decision, always, balancing the risk and the benefit for that particular patient, because the patient is very happy to gamble, but we need to give them the honest odds, okay? And the patient usually is happy to trust the doctors, but we just need to be honest with them. And at the end, if you want me to give you a good take-home message, the assessment, the decision-making is absolutely key. It's all about get it right the first time. And sometimes one of the message would be think twice, cut once, because probably sometimes, not always, but sometimes we need to deal with this lesion another time. Maybe somebody else can do it better than us. Maybe somebody else in a different hospital can do it better than us, all for the best of our patient, of course. Thanks.
Thank you, Fabio. I think Sukumar will have any comments?
Yeah. My question was like, you were saying about the biopsy. It's something which I did not really understand. You're saying that the biopsy need not be done on a regular basis, or if you suspect that it is going to be benign, you wouldn't biopsy it. Was it that?
Yeah, this is a tricky question, because it's not that biopsy is never useful. When we see this polyp, they look completely benign and there are no suspicious area. Usually there is no point biopsy them, because the biopsy will always come back as benign, and we induce scarring, which may make challenges subsequent endoscopic excision of the polyp. So we may cause a problem to the endoscopy who's going to remove this polyp later. But clearly, if there is a suspicious area, for example, a large lateral spreading tumor with a dominant nodule, or if there is a depressed area, it's probably right to take a biopsy, because the depressed area may harbor a cancer. So it's not that it's never useful, but we need to really think very carefully whether we're doing something good in biopsy the lesion that looks completely benign.
So would you go by the SMSA score? This theoretical knowledge to me, but then would you go by the SMSA scoring to decide whether you go for a biopsy or not?
Yeah, possibly.
Possibly. Okay.
So I think Sundeep will be answering that question, because that is his topic, and we'll finish off and then come back to discussion.
Fine. That's okay.
So Dr. Sundeep, can you go ahead with your talk, because you can.
Yes. Do you have my slides?
Yeah, no. First, Dr. Fabio has to stop sharing his slides. Then perhaps you can. Dr. Fabio, yeah. Yeah, now I can see your slides.
Okay. Thank you, Dr. Chandramohan and the entire group. I'm probably one of the exceptions in this entire group of webinar, where I'm probably the sole endoscopist, or maybe a few people are there who are doing colonoscopy. But I'll be covering the early stage lesions, endoscopic managements of complex Specc. It was a very nice talk by Dr. Fabio, and I actually learned a lot as an endoscopist, the surgical perspective. So I would divide my talk in this way. What does endoscopy give us in the colorectal polyps? First, we evaluate it using high definition endoscopies, which are now available, and then make an assessment whether this polyp is resectable or not. If it is, then what method should we use? It is endoscopic mucosal resection or endoscopic submucosal dissection, which I'll touch upon later in my talk, and what to do for the difficult lesions. Having said that, there are various factors, as Dr. Fabio also elaborated, was the patient factors, the lesion factors, if they are in difficult locations, size, etc. Endoscopist expertise, efficacy and complications associated. Are you ready to tackle these complications if they happen to occur? All these factors dictate who and where these polyps can be managed endoscopically. The lesions which look very classical adenoma, or even have high grade dysplasia on biopsy, and if resected and have the specimen shows that the submucosal invasion is SM1, that is less than 1 millimeter or 100 microns, then it looks quite okay that you can go ahead and resect. But if the imaging suggests, or endoscopic imaging suggests, that this may have a submucosal invasion of more deeper submucosal invasion, or it's very unfavorable location where you're unlikely to complete the job, or the polyp is adherent to the base and not lifting or injecting a saline in the submucosa, then these features suggest that this polyp is going deeper and we are unlikely to do a complete job endoscopically. And that's why in in this tumor boards, we discuss these things and take a decision. The imaging on the bottom, the endoscopic imaging gives us a gross appearance and white light. And then we can have chroma endoscopy, which can be done in two ways, by spraying dye on the surface, or nowadays most people do the electronic chroma endoscopy, which is narrowband imaging and other variants of that, and even magnify the lesion. I'll show some videos of that, how we make an assessment. Moving forward, this is one of the earlier classification or Paris classification, which makes us assessment of the superficial polyp by surface morphology. There are basically two categories. The polypoidal variety has a classical pedunculated polyp, which can easily be resected endoscopically, or they can be sessile polyps. If they're less than 2 centimeters in size and can be lifted up easily, they can be resected by an EMR. Polyps which are flat can be categorized into 2A, B, and C, depending on whether they're slightly elevated above the colonic mucosal surface, or they're just flat and merging with the surface, or they are depressed polyp. The depressed polyp and the excavated polyp have a higher chance of a deeper invasion, submucosal, or they can have a lymphovascular infiltration, or sometimes nodes also. So let me show some examples to you. These are the appearance of a polyp which is slightly elevated, a large flat polyp, a homogeneous granular polyp, and the one on the left has about 0.5% of a submucosal invasion. But on the right side, it is similar looking polyp, but it has multiple nodes and nodules in between, dominant nodules. And whenever they are dominant nodules, then the risk of the invasion, submucosal invasion risk, goes up to 10.5. So that's why a close inspection of the polyp at the first colonoscopy is the most important thing. Now let us look at the non-granular polyp, which are flat. The risk is about 5% of a submucosal invasion. But if they have a central depression, which takes the risk to 1/3 of them would have either a malignant potential or already have invaded below. So let's look at how narrowband imaging tells us the submucosal invasion. So this is nice classification, which is NBI, International Colorectal Endoscopic Classification, or NICE, quite well followed world over. It's a uniform classification, and based on the surface pattern and the vascularity of the polyps, they are categorized into type 1, 2, and 3. So if you look at it based on color of the polyp, is it similar to the background, a little browner or brown to dark brown? Presence of the vessels which are normal or they are irregular and disrupted vessels, and the surface pattern. A conclusion of type 1, which is a hyperplastic polyp, and sometimes small ones can be left behind and large ones can be removed and subjected to histology. Type 2 are adenoma, and type 3 are deep submucosal invasive cancer. So type 3 goes straight for surgery. Type 1 either can be left behind or can be removed and subjected to histology. It's a type 2 which is most important. Let's watch this video with a small polyp there. You do an NBI, you see the surface pattern here. Its the size is small. Smaller polyps have a less chance. This one looks like a hyperplastic. A different polyp, which has multiple protuberances, a larger size, is sessile. And if you look up closely with magnification, with an expert eye, you see these vessels are abnormal. They are depression in the center. And this tells us that this may have a submucosal invasion. This comes with practice. And the Japanese are best in it. And soon the rest of the world is learning from them. So the type 2 polyps can be low-grade dysplasia, can be high-grade dysplasia, and can have cancer with superficial submucosal invasion. So if all three can occur in type 2, then how do we proceed further? And that's a drawback of NICE classification. So can it be nicer? So the JNET classification, which came from the Japanese expert group team, they divided type 2 into further type 2A and type 2B based on the surface pattern and vascularity. And So type 1 remains hyperplastic or sessile serrated. Type 2A is low-grade dysplasia, so can easily be removed. Type 2 has a risk of malignancy, and type 3 has a deeper submucosal invasion. So these are the differences that we observe. So lesions which are type 1 and type 2A can easily go for endoscopic resection. Type 2 is still a debatable area, but most endoscopists feel that we can remove it and then subject to histology. And if you find that the invasion is more than SM1, then they can later be subjected to a surgical resection. Whereas type 3 straight away go for surgery. So these are the polyps, flat polyp. So you look at the dark spots, which are the crypts, magnified further. So you get beautiful images. So based on the crypt and the vasculature, you can define it as hyperplastic polyp, or look at this, a very flat polyp can miss out on routine endoscopy. And that's why one needs to spend time in colonoscopy to withdraw and clean up the mucosa and then inspect carefully. That's why the withdrawal time has been designated to be 6 to 7 minutes. You should not come out fast, spend time in watching each area carefully. And look how beautifully somebody can make out these flat polyps. They're still type 1, but now as the size becomes bigger, you magnify them further by just pressing the button on the high advanced endoscopes which are available now. So you can see the crypt pattern and the vascularity, the surface, the color. And just by looking at it, you can differentiate these features and classify into one category or the other. This one is 2C or 2B and 2A. So some areas can have the mild dysplasia and some have a higher grade dysplasia. Just by the appearance, mind you, the biopsy has still not been done. And this is a high grade lesion, which is more likely to be malignant, and this one goes for surgery. So I just wanted to make you aware, because it's mainly a surgical forum, that what all colonoscopy and endoscopy with the current technology can do. So what type of endoscopic treatment should we consider? There are two main varieties. It's called EMR or endoscopic mucosal resection, which can be done as an en bloc, especially for lesions which are less than 2 centimeters in size. In the colon and rectum, about 25 millimeters can be removed en bloc. But if they're bigger than this and still superficial, they can be removed piecemeal, as the name suggests. And some new variations have come where you can do underwater EMR. But lesions which are bigger but still look resectable, one should consider doing an endoscopic submucosal dissection, which is a time-taking process. Somebody needs to have patience, and there are hybrid forms of it. So coming back to the same image that I showed you earlier, this lesion and this lesion, which have less chance of submucosal invasion, can be considered for EMR because they're large in size. But the lesions which have the prominent nodules or depression in center may be considered for endoscopic submucosal dissection if expertise is available. And mind you, this specimen should go to pathologists and they should give a final answer whether the submucosa is free and the margins are free of the tumor or not. So EMR is quick, cheaper, short learning curve. You can do en bloc resection in about 50%. Perforation is much lesser compared to endoscopic submucosal dissection. But even if perforations occur, nowadays we have good equipments, clips, a variety of clips are available which can seal off any perforation. Even full thickness perforation can be taken care of, and so is the bleeding. They are best for lesions which are 25 millimeter or less, but can also be done for larger lesions. Let's see a couple of videos here. There are two large lesions, as you can see. I'll playing both of them simultaneously to save time. And they're a little edited, so moving fast forward. So you inject on the sides with indigo carmine and saline mixed. So that helps us in lifting the lesion, and lifting is very important. That tells us that that lesion is not tethered below in submucosa. It also helps us in preventing the complications. So basically you make a thick pedicle in indirect terms and try to resect either in one go, as seen on the left side of the frame. On the right one, we are doing it piecemeal, but piecemeal should be as less pieces as possible, and all the pieces then should be trapped and then sent for histology. So the end result you can see here. You'll just be getting that image. It's a nice, beautiful resection of both on the left and the right frame. Coming to ESD, the advantage is that you get one single large piece of the entire specimen. So pathology or histological assessment is precise and complete, and there is less chance of local reoccurrence, which is commoner in EMR. But the limitations are it takes longer time, higher technical skills, and more complications that can occur. As you can see a perforation here, we can see the peritoneum here, and this is a bleeding spurter here. So how do we do colonic ESD? This is a large lesion, a flat large lesion. Again, you make an injection, lift it up, but here we use a knife. It's like a needle knife, which after making marks at the edges, then we join all those dots and make a circumferential resection. I'm sorry for this video being a little faster because of the time I had to edit it in such a way. On an average, ESD, a large lesion, takes about 45 minutes or an hour or sometimes more as well. And as Dr. Fabio said, if biopsy is taken before, multiple pieces are taken before, it can cause fibrosis, and that makes the ESD more difficult. So if you're considering ESD, just either do directly ESD or take one piece, and between the first biopsy and the ESD time should be as short as possible. Preferably within 3 days, if we can do the resection, then the chances of a good completion is better. So this is the end result that we see. So let's talk about the reoccurrence after EMR and ESD. In Japanese hands, after ESD in the superficial lesions, the risk of reoccurrence is 0% in 3 to 5 years. But for EMR, this is not so efficient. The recurrence can be 15%. It can be piecemeal or en bloc. If you do en bloc, that is much better. Then the reoccurrence is less. But if not possible, it may not come in one snare, then you have to do piecemeal, and then the recurrence can be 1 in 5. And that's why we need to keep a follow-up of the patient, how we have approached in resecting the tumors. Also, recurrence can be based on the size of the lesion. If it is more than 4 centimeters, or there was a bleeding at the time of removal, or it's on high-grade dysplasia, then the risks are much higher. So how to prevent reoccurrences? So once you have made a lesion like this, as a piecemeal EMR or a one complete EMR, these margins can be touched with soft coagulation, which even there is a non-visible lesion, and you make it entire white at the edges, that is shown to reduce the risk of reoccurrence even in piecemeal EMR. Also, there's something called as cold forceps eversion and adjuvant snare tip soft coagulation, something similar, where you burn the edges so that even there are residual microscopic lesions that also get burned. The risk of reoccurrence is much lesser after cast. But if somebody has tried and failed to remove the entire lesion, then what we can do is full thickness resection using a special kind of a clip called as Ovesco clip. As you can see it here, this is a depressed lesion. So a forceps is passed through the clip, holding the lesion and pulling it inside the lumen of the cylinder transparent hood, which has a clip at the tip. And once you get the entire lesion inside, then you fire the clip. Once we have fired the clip, we do a polypectomy, which is actually a full thickness polypectomy now. You can, in the image in the end, you can see there is the fat of the peritoneum, which is seen, but since the clip is nicely applied, this perforation automatically gets closed. So once we have resected the lesion, what's next? So obviously, we see at the histology, which is very important of what we have done. If the deep submucosal invasion is there, as I said earlier, or there's lymphovascular invasion, or the biopsy comes as poorly differentiated malignancy, there's a positive vertical margins, or there is tumor budding on histology, any of these features are present, this patient should be sent for surgery, even if you have removed the tumor, but any of these findings, because there is high risk of reoccurrence. But if none of them is there, then in a piecemeal resection, you follow them after 3 months, do a repeat colonoscopy, look at the lesion and take a decision accordingly. If it's a full resection by EMR at one piece, then you can do a 6 monthly. But if you've done a good job at ESD, then a 1 year follow-up is required. So in conclusion, accurate assessment by endoscopy with high definition endoscopy and chromoendoscopy is important to make a decision whether the patient should be taken up for endoscopic resection or should be sent for surgery. If the patient is selected for endoscopic removal, one can choose EMR or ESD. Always ESD is preferred, especially for larger lesions, but for smaller lesions or borderline lesions, EMR can be done, but it's all based on expertise. Always take a final decision based on a reviewing of histology and then plan your follow-up accordingly. Thank you very much for your kind attention.
Thank you, Dr. Sundeep. Srikumar Pilla sir, can we finish the next talk and then come back to discussion?
Sure.
I think that is better. Dr. Tracy, please go ahead with your presentation. Yeah, I think.
So can you see my slides?
Yeah, we can see.
Okay. So good evening, everyone. My name is Tracy. I'm a consultant pathologist working in SGH, which is Singapore General Hospital. Today, my topic is unexpected cancer in a polypectomy specimen. This talk will cover the following topics: the spectrum of adenomatous colonic polyps, classification of invasive adenocarcinomas arising in polyps, along with the issue of mucosal displacement. It will also talk about what we as pathologists look for or try to look for when we diagnose a cancer. And finally, I'll touch on issues in margin assessment. In my institution, we've got, apart from the usual biopsies and polypectomy specimens, we also have endoscopists who do EMRs, ESDs, full thickness resections, as well as surgeons who do TEMS, which is the transanal endoscopic microsurgery. First, a bit about polyps. Conventional colorectal adenomas are benign, pre-malignant neoplasms composed of dysplastic epithelium, which can be low or high grade. Ideally, at low power, the polyp would look like this with the distinct adenomatous epithelium seen here. The tubular glands are fairly discrete and separated by lamina propria. Moving on to adenocarcinomas. Invasive adenocarcinomas, as defined by the AJCC 8th edition, are when the tumor extends through the muscularis mucosa into the submucosa or beyond. This happened to be a section from a transsphincteric resection, which was performed from a low rectal sessile 2 cm polyp. Because the specimen came like this at the time of gross examination, it explains why the sections were very well oriented. In this image, the blue arrow indicates the muscularis mucosa, the green arrow indicates the muscularis propria, and the red arrow indicates the tumor, which can be seen extending past the muscularis mucosa, as indicated by the yellow line into the submucosa. This is the tumor here. For carcinomas arising in a polyp, the AJCC 8th edition manual classifies them according to the PT definitions adopted for colorectal adenocarcinomas, which means that tumors have to invade through the muscularis mucosa and enter the submucosa of the polyp head or stalk to be classified as T1. This shows a section from a large sigmoid colon polyp, and ideally, if I had to diagnose an adenocarcinoma arising in a polyp, I would like to have the adenocarcinoma look much higher grade than the background adenoma, as indicated by the blue arrow. This is a higher power view from another area of the polyp, which shows the irregular glands in a spindled desmoplastic stroma. So in this scenario, I'm quite comfortable diagnosing an adenocarcinoma arising in this polyp. Some cases are more difficult. This case was a sigmoid colon polyp. Some areas had hydrate dysplasia. An examination of the neck of the polyp showed this pool of mucin which contained dysplastic epithelium. This is a higher power view of the dysplastic epithelium. As such, this was best considered as a focus of mucinous adenocarcinoma. This is another sigmoid colon polyp, which at higher power shows this cluster of glands with a lobular outline within the polyp. This is highlighted in yellow. The glands in this case are still tufted by lamina propria, and there's no obvious desmoplastic stroma identified around the glands. The glands are also lined by low-grade epithelium, which is similar to the background adenoma, with no high-grade dysplasia seen. This would be in keeping with epithelial displacement. This is another sigmoid colon polyp, which is a rather scrappy specimen. Unfortunately, so in this case, there were these islands of low-grade adenomatous epithelium which were displaced into the underlying stroma. This is a higher power view. It shows the adenomatous epithelium highlighted in yellow, and the outline is relatively smooth. The glands are also accompanied by lamina propria, and in other fields there were areas of hemosiderin. After multiple levels, which I showed to my colleagues, we agreed that this was in keeping with epithelial displacement. So epithelial displacement or pseudo-invasion refers to the presence of glandular epithelium beneath the muscularis mucosa in colonic polyps. It often occurs in large polyps, especially those with long stalks. What this looks like is there are rounded islands of epithelium which carry some lamina propria. They're cytologically identical to the overlying adenoma component. And sometimes because the glands have mucin, the glands can become cystically dilated, and then the mucin can rupture outwards with an inflammatory response. This can mimic a mucinous adenocarcinoma. But I mean, ideally in a mucinous carcinoma, we would hope that the mucin pools contain malignant cells, which should not be present in pseudo-invasion. That said, sometimes the distinction can be difficult. A few slides ago, I said that the AJCC 8th edition required invasion of the submucosa to call a PT1 lesion. AJCC also has a PTIS category, or in situ category, where the carcinoma does not invade the submucosa. It defines it as the invasive carcinoma limited to the muscularis mucosa and or the lamina propria. And honestly speaking, I find this category really difficult to use. So this was a rectal polyp from an 83-year-old male. In this slide, it's fairly well oriented. When we zoom into this area, we find that these glands are more complex. They have a more complex architecture. There's actually some epithelium in this inflamed area, but it's difficult to see it at this power. This is the CAM 5.2 immunostain section, which highlights the epithelium and shows these irregular glandular elements here. This is a low power of the Desmin stain slide, which shows a relatively intact muscularis mucosa layer. Side-by-side comparison of the CAM 5.2 shows these irregular glands and these tiny little bits of epithelium, which may represent tumor budding, located above the muscularis mucosa as highlighted on the Desmin. So because the tumor is all above the muscularis mucosa, it would probably be best considered a PTIS lesion or an in situ carcinoma. Why we bother at all is because an in situ tumor resected with a clear margin during endoscopy is stage 0, and it has a low probability of nodal involvement such that nodal resection is not justified, according to the AJCC 8th edition manual. That said, this category is really difficult sometimes because I end up having to do multiple levels just to make sure that it hasn't actually involved the submucosa on deeper levels, and then I end up showing the case around to my colleagues just to get some sort of consensus. So moving on to what pathologists look for when we find cancer in a polyp. Because malignant polyps have a risk of lymph node metastases or local recurrence, the CAP cancer protocol recommends that we evaluate certain histologic factors such as histologic grade, status of the resection margin, and lymphatic or venous vessel involvement. An increased risk of adverse outcome has been shown to be associated with high-grade carcinoma, tumor at or less than 1 mm from the resection margin, and lymphatic or venous involvement. This was one of the rare times when I found lymphovascular invasion, and this happened to be a section from the Thames case which I showed earlier. Lymphovascular invasion has been shown to be an independent predictor of lymph node metastases in multiple studies, and the differential sometimes is retraction artifact, in which case immunostains for D240 and CD34 can be helpful. Additional factors that the CAP cancer protocols advocate reporting include tumor budding and the depth of area of submucosal invasion. This diagram shows the classification system for pedunculated polyps developed by Haggett et al., which most people are familiar with. And the next few slides are examples of some of the most convincing polyps I could find that have different Haggett levels. This was a large sigmoid colon polyp from an 80-year-old male which was trisected. And in this section, the tumor can be seen in the submucosa. The advancing edge of the tumor is this line in yellow, and is mostly limited to the head of the polyp, which would make it Haggett 1. This was another sigmoid colon polyp with an adenocarcinoma invading the stalk of the polyp. In this section, the blue arrows show where the normal colonic mucosa starts, and this area where the asterisk is where the adenocarcinoma is. On higher power, we can see that it's just in the stalk of the polyp, which is Haggett 3. The Haggett system applies to pedunculated polyps and doesn't really characterize sessile lesions well, which is when they develop the Kikuchi classification for depth of invasion into the submucosa for a sessile malignant polyp. That said, it can be difficult to use because the muscularis propria is not usually present in biopsies. This schema was proposed by the Japanese Society for Cancer of the Colon and Rectum as a method to measure the depth of submucosal invasion. Basically, it divides tumors into pedunculated and non-pedunculated tumors. And for non-pedunculated tumors, the depth of submucosal invasion differs depending on whether the muscularis mucosa is present or it's not present. Again, it can be really difficult to use if the specimen is not well oriented. Finally, we'll move on to margin assessment. And after some lit search, I found a paper from Hadrian et al. That defined the free edge of the submucosal connective tissue with cautery artifact as the true margin of resection. That said, depending on how the tissue is trimmed or embedded, the margin may be difficult to assess. For example, in this polyp, which was resected piecemeal and received in multiple fragments, we can't really see cautery artifact. So it's kind of hard to identify the margin in this case. Ideally, for good margin assessment, it's good to have a well-oriented, well-fixed specimen. And this was an ESD specimen which was oriented by the doctor performing the procedure and received by the lab pinned to a styrofoam board. This produced this section after trimming and processing, which we can see the adenoma up here, and these pools of mucin at the deep aspect of the polyp. Higher power view shows malignant epithelium with increased nuclear to cytoplasmic ratio floating in pools of mucin, which extend all the way to the inked deep margin. This was a sigmoid colon polyp from a different patient with a moderately differentiated adenocarcinoma set in a spindle desmoplastic stroma. And at the margin, we can see cautery artifact on malignant glands which were less than 1 mm from the margin in this case. This is another sigmoid colon polyp with a adenocarcinoma up here. This is the cauterized margin, and you can see that because the specimen is really well oriented. At this power, the tumor looks clear of the margin, but when we zoom in, you can see cauterized glands less than 1 mm from the cauterized margin. So in summary, for pathological reporting, it would be really good if we had good well-fixed, well-oriented specimens, because it makes the reporting of adenocarcinoma arising in the polyp very much easier. If the specimen is an EMR or an ESD, pinning the mucosa to a board helps to fix the specimen flat, which makes for sections which are much easier to orientate. And sometimes if the margins are really difficult to assess, correlation with endoscopic findings is recommended. I picked the really nice cases to photograph actually for my talk. So sometimes I don't get specimens that look like this. Anyway, this brings me to the end of my talk, and I'd be happy to take any questions.
Thank you, Dr. Tracy. Dr. Sivamarula sir, we can go to discussion.
Yeah.
Whatever you discussed.
Okay, Dr. Sundeep, are you there?
Yes, yes.
Yeah, I had a small doubt. How would you mark, suppose you feel that it is malignant and the surgeon has to go for a subsequent resection. So how would you mark and show it to the surgeon? What is the material that you use and any distance from the lesion that you would mark? Is it on the anal side or the oral side?
Yeah, that's a very good question. So I did not cover that in my talk because of time, but we mark about 3 centimeters towards the anal side of the polyp using either India ink or carbon particles, which stay there for long, so that it should not be very close to the lesion. At least 3 centimeters or away should be where, and at least on 2 margins opposite to each other, so that helps surgeons to localize the tumor, and they can then decide about the resection margin.
And what is the material that you use for lifting?
So
is it saline or something else on a regular basis?
So the best material which is recommended is carbon particles, which comes as a powder which you can make as a solution, but it is very fibrogenic.
Okay.
That's why it has to be a little distance, and it has to be injected. Once you inject saline, raise a bleb in the submucosa, and then you inject these particles. But more often than not, we use India ink, which comes as a solution, and that is injected about 3 centimeters distal towards the anal side of the lesion.
Yeah. I was just reading about this ESD and EMR, and this hybrid. What exactly is the difference? If you make a scar and then you go beneath it, I really didn't understand that.
So there are various types of ESD, in which if you have a polyp in the center, you mark the spots around, take a very fine knife which projects about 1 millimeter or 2, and keep incising all around and clipping the vessels or coagulating the vessels in between. It's like a slicing all the way through and then removing the tumor. That's the conventional or the classical type of ESD. In the hybrid form, you cut on all sides, then the center now is protruding out and becomes like a pedicle. So you can use a snare and then chop it off.
Okay.
You need not do all around. You can just go from one side, 180 degrees, make an incision, and then keep digging inside it till you reach the other end. So these are some variants of that.
And to the pathologist, I mean, like, how would you assess the margin if the specimen is piecemeal?
If the specimen is piecemeal, generally I can't really give you a radial margin.
Okay.
I can't tell which margin is the true radial margin. I can give you a deep margin if it's well oriented and I can see cautery artifact at the deeper part.
No, I would ask. Suppose the endoscopist has done a resection and it is a histological surprise. Of course, I am aware that the endoscopist would be able to probably predict whether he is dealing with a Specc or not. If by any chance that there is a error in speculation, because I read an article, Specc and the speculation of Specc, something like that. So, like, then how would the pathologist address that issue? Would a resection be recommended to the endoscopist or to the surgeon if needed?
So, sorry, if I can answer to this. This is a common scenario, actually.
Okay.
We always ask whoever did the polypectomy, because if the endoscopy in honestly said, yes, I did completely remove the polyp, we have to trust him or trust her. and so we need to assume the polyp has been completely removed. So now the question is mainly the deep margin. Okay?
Yes.
So if the deep margin is involved, that's a different story. Then we need to discuss with the patient about the risk of cancer coming back in the lumen and in the lymph nodes. But with respect of the peripheral margin, we often ask the endoscopists whether they feel honestly whether the polyp has been removed completely. Because sometimes there is always a millimeter of margin which has been burned by the snare or by the ESD device, which actually burn a little bit of cells. So it could be that actually the margin is completely clear, even if the pathologist will tell you that there are some cells just there.
Mm.
Dr. Fabio, how difficult is it to re-excise by EMR and ESD a lesion which has recurred at the same site?
Yeah, I'm a surgeon, so this is usually is our endoscopists who deal with these problems. Probably Sundeep can answer to this question better than me.
What is your experience, Dr. Sundeep?
So when we do a piecemeal polypectomy, that's why we call them at about 3 months to have a relook.
Okay.
And also biopsy any suspicious lesion. Also look with high definition endoscopy for biopsying that area. And any suspicion which is confirmed, I think either we can do a full thickness resection if possible, or then refer to a surgeon. These are two options that we have. So piecemeal polypectomy patients should be more closely followed up compared to those who have one single piece either removed by EMR or ESD.
Can we do something with let's say for a rectal polyp at around 10 centimeters? Could you use a rigid sigmoidoscope and do something? No, it's not possible.
That you can, I think surgeons can answer better.
Okay.
Some interferences.
And I would like to add, I would re-emphasize what I said earlier in my talk is if you're doing are you able to hear me, Dr. Srikumar?
There's some background noise. Yeah.
Okay. So I would re-emphasize that when we do a piecemeal polypectomy,
Okay.
because we are not sure whether the lateral margins have been taken care of or not, it is always better to do a soft coagulation of the entire edge, like a paintbrush. You'd keep touching all over, and this has shown to reduce drastically the reoccurrence rate, which we are all worried about.
And endoscopy at difficult location, cecum, appendicular orifice, and the flexures, folds. Any tips for the endoscopist?
Yeah, that comes with experience. I think gradually we can do it. But I think it is better to keep an expert person next to you when you're doing it in the beginning, or watch those experts carefully to learn the tips of the tricks of the trade to how to tackle that. Or keep a surgeon ready just in case we create a mishap.
Yeah.
Dr. Srikumar, can I ask you something? Because we are going, I will launch a poll. All the attendees, even panelists can vote on the poll. I like to know their opinion about certain aspects of polyps. And there are also some questions in the question answer session. And if all the panelists, if you can look at that and answer that, it would be nice. So I like to ask a question to the earlier discussion. Actually, being a surgeon, the talk by Dr. Sundeep was a little eye-opener for us. So we used to think that when you have a polyp, you have to do some kind of imaging first, and then biopsy, then decide. So now I'm understanding slowly that more than these three modalities of assessing, you have one more modality called careful endoscopic inspection, where you are looking the narrow band, you are looking the movement, you are looking in the various patterns, or you are predicting that chance of malignancy. So in that question, if it is a Specc or a large polyp, which is quite doubtful, and you are doing an endoscopy and you are finding such a lesion, So will you decide on table, am I going to go ahead with the resection, or I am going to do a biopsy, or I am going to send it straight across the surgeon because this looks a little advanced. So Dr. Sundeep, can you comment on this?
So if the polyp looks high risk of malignancy, which is mainly by the size and the vascularity and the surface, other thing, irregularity. So, and we can take a small piece. Our general tendency is to take many bits of pieces and send it for histology. But each biopsy causes scarring, and which will hinder to our next planning of resection endoscopically if you're planning to do that. So take it from the most high grade area on white light endoscopy of high definition variety, along with magnification, which is now available in most the current endoscopes. And if you take 1 or 2 bits, most biopsy reports comes in 3 to 5 days time. Don't try to do big pieces and many pieces. And if it looks amenable to resection, you can talk in the tumor board with your surgeons and the pathologists as a report comes, and take him up for resection, either by the EMR or ESD. After telling the patient that just in case if the deeper margins comes as more than SM1, as Tracy was saying, then he can then be subject to surgery at a later date. But if luckily that the lesion is PT1 or SM1 lesion, then he can just be followed up.
Thank you. And unfortunately, what happens is, at least you know that in our part of the country or across the globe, the number of skilled endoscopists who are able to resect it in toto are very less. So, Dr. Sundeep, you are a very rare species. So, so many of the times we surgeons end up with a little bit of biopsy and piecemeal excision, and then we may have to go ahead with a surgery. I think in all across in India, I'm sure, and all across the globe, the surgery being overused for similar kind of polyps because we don't have expertise in the endoscopic management.
Yes, removing a polyp is actually sometimes a diagnostic thing also. If we have done a complete job, we stop there, but if we have done an incomplete job, then we pass on to a surgical colleague. So that's why the multidisciplinary meetings are important with the patient and the pathologist, so that these things can be discussed and there is no controversies which then come later on. We are all learning from our Japanese colleagues who are masters in this trade. We have now experts all over the world, and this is a very exciting area of endoscopy, and some people have just taken this NBI and surgical endoscopic resection as a subspecialty of endoscopy. So now we have endoscopy for pancreatobiliary is separate, endoscopy for colonoscopy is separate. In fact, for Japanese, they have Japanese EMR ESD only for upper GI, and a separate guy who's doing colonic EMR ESD. So is in UK, as Pradeep Bhandari and Sunil Dolwani are experts in UK.
I think UK experts are Indians mainly.
It's a very time-consuming process, and it's an art on its own. If you see the Japanese performing these EMR ESD, it's an artist who is making a Mona Lisa.
Great. And I think I have a question also in the poll. Which imaging, like the UK School of Thought is seeing and do an MRI, especially in case of rectal polyps, MRI and evaluate. But I think in many other parts of the world, you rely on more on endoscopic ultrasound. So when you have a significant polyp in rectum, so what is the protocol in Dr. Sundeep? What is your protocol and what is UK protocol? The big polyp, will you do an endoscopic ultrasound or MRI?
So if the big polyp is there, I would do an endoscopic ultrasound to see the deeper invasion. If it looks like a T2 lesion, then he goes for surgery. T2 and beyond, then he is managed differently. But it's limited to, we can see the layers of the rectal wall, just like the gastric wall very nicely. And it's very easy to differentiate which layer it is reaching up to. And any feature which shows it is going beyond the third layer, that is submucosa, then he goes for a different treatment. But if it's limited to the surface, then we definitely offer it a resection, which is a diagnostic cum therapeutic. And then the Tracy and my histology colleagues will then tell us that have we done a complete job or not, and then what we need to do follow up.
So Dr. Fabio?
We always do MRI and endorenal ultrasounds, both of them, and we strongly believe they're complementary. We do the MRI essentially to stage the mesorectum, okay? Because clearly, if there are negative features in the mesorectum, these raise suspicion that this can be the cancer. But we need to be careful the MRI overstage this polyp, because the classical answer we have from the MRI radiologist is this polyp is T2 or less. And this is not enough for me because this could be benign. That's why the ultrasound scan, the endorectal ultrasound, is really helpful to identify whether this polyp is actually invading the mesorectum, invading the submucosa or not. And this is something that is very easy, but very difficult for an MRI to achieve. There are no clinical trial at the moment, and we are thinking about doing a national trial in the UK to see whether actually MRI is able to differentiate between a benign Specc, T1 versus T2, but the evidence is not there yet. So to answer to your question, we use both.
And one more question. I think one important issue is the polyps won't come alone. They come in groups. So many times we may be working with a patient who is having an index cancer, and you see many polyps all around, and none of them are malignant on biopsy. So what is the protocol? Would you like to address those polyps as well, or would you like to excisions? And I am not talking about not the FAP kind of stuff. A few polyps here and there. So there are questions also people are asking.
So this question is addressed to me?
I think both of you can answer.
Okay. So
yes,
yes,
there's an index cancer and few polyps.
If there are synchronous polyps in other parts of the colon, and if they're look to be say a centimeter or less than 2 centimeters, we would try to remove them. And again, before surgery, that histology will guide us. If that comes as a deeper invasion, then you can decide your surgical management appropriately. It can be a extended colectomy or a total colectomy, depending on where they're located. So all these polyps for the endoscopist have to be labeled differently, except in a different bottle, as Tracy was there. So the markings have to be made, which area which has come from, so that decision making then becomes easier. They can't be put in bottles.
Otherwise, what I am asking is, if you have a lot of polyps, also a cancer, and we also know that the cancer, the colorectal carcinogenesis is a sequencing process from polyps to cancer. And is the person is having increased risk of having colon cancer anywhere else? And is it not safe to do some kind of colectomy prophylactically rather than taking away polyps and waiting for the polyps to come up?
So that's a little debatable area. If there are, at what number of polyps one will decide that total colectomy should be considered. Leave aside the FAP or the other hereditary syndromes, but they are little more predisposed and they have to be more rigorously followed up. I think Fabio can answer that better of whether you want to do a, my personal take would be that if there are say less than 10 polyps, I would remove all of them and send in a separate bottles to a pathologist. And based on the biopsy before the surgery, we take a call. If they are closer to the index cancer, then and those lesions are high grade and a deeper invasion, then that area can also be resected. But if they look to be reasonably cleared of the margins and they are of not the high grade variety, then we can closely follow up with a surveillance colonoscopy post surgery.
Yeah, one more question to you, and perhaps then I will go more to for Fabio. Suppose if you have small diminutive polyps and it is not FAP, you know that you biopsy the bigger ones, excess bigger ones, then all of them are not having any malignancy, but there may be dysplasia. So what about other polyps? Are you worried about that, or will you observe those polyps?
So that's a very good question. So now with these high definition endoscopy, we can easily make out whether these diminutive polyp that is less than 5 millimeters, what is the chances? Most of them are hyperplastic polyps, which can be in association with a malignant cancer elsewhere, and they can just be left like that. Okay. Or if you have a fear because you have an index cancer, that's best you can do a cold snaring, which is now a current preferred modality compared to a electrocoagulation or a surgical cautery kind of a cut. So instead of doing a hot polypectomy, we can do a cold snaring and then send it for histology. So there is a debate going on if you leave aside any, so if you're doing a colonoscopy in any patient who does not have a cancer, who comes for routine colonoscopy and you find these small polyps, either we resect and leave because this puts a burden on pathologist, or inspect and leave depending on if you're very confident of the appearance. Like hyperplastic have a very classical appearance, and there's no point putting the patient on anxiety and the burden on the pathologist and the overall setup. We can choose to leave them alone.
Dr. Fabio, what is your opinion?
So the classical scenario of a cancer with several polyps, you need to remove as many polyps as you can. Let's say the classical scenario, 5-6 polyps. You leave alone the polyps that are close to the cancer, because this will come out with the specimen, and you try to remove the other one. Okay. The other question is whether this patient needs genetic counseling eventually, because clearly if there is a genetic mutation, and then it's a different ball game. So we have clear guidelines from the British Society of Gastroenterologists. If somebody less than 60 years old has more than 10 polyps, should be referred for genetic counseling, okay? Or if somebody is more than 60 with more than 20 polyps, again, should be referred for genetic counseling. But again, in terms of management, again, I would try to remove the polyp away from the cancer, and I will do a resection, possibly including the polyps close to the cancer. Every patient will have a colonoscopy 1 year after surgery, but I wouldn't think about doing a colectomy, absolutely.
Thank you. Dr. Segamarule? Dilip, would you like to comment? I'm seeing Dilip. Yeah.
No, Chandramon. I'm just listening to your
yeah, Fabio was asking about you from yesterday onwards. Please.
I'll join later.
So I think Dr. Fabio, are you?
Yeah. No, go ahead.
Yeah. So the idea of not doing biopsy before polyp excision, are you very, very strict in that, or are you lenient?
No, I changed massively my management, mainly thanks of endoscopists, major endoscopists. You mentioned some of them. Most of them are actually Indian, the best endoscopists we have in the UK. And I used to biopsy everything. Now I biopsy almost nothing. So I biopsy only if there is a lesion that it looks like a cancer, okay? Because of the pit pattern, because it is an ulcer, I then biopsy them. But if I think there is a chance can come out endoscopically, I do not biopsy. And I enjoy a lot the talk from Tracy, because she also showed another disaster that can happen as a consequence of the biopsy, which is epithelial displacement, okay? Because you push the mucosa inside, so when you take the polyp out, this looks like a cancer, but actually it's not a cancer. So you actually end up doing an unnecessary operation to a patient as a consequence of this epithelial displacement. And it's a major issue that sometimes when there is controversy, we ask for second, third, up to the fifth opinion in the UK. There is a group of top pathologists in the UK which are happy and able to answer to area of controversy like epithelial displacement. So its potential is very dangerous. Again, it's not a no, a definitive no, but it must be done very selectively.
Good, thank you very much. I think there is a question from one of the delegates. If you can't reach beyond the growth, and there are, how do you evaluate the remaining colony? Will you do an intraoperative endoscopy, or will you do it after the surgery?
So sorry, say it again. If you can,
there is a lesion, and you are suspecting polyps in the proximal colon, and you are unable to pass your endoscope. And while you when you do surgery, will you do an intraoperative endoscopy, or will you do afterwards?
No, I'll do a CT colonography first of all,
okay.
Because I want to see whether there is a proximal cancer or not. If proximally there are only polyps or there is nothing, then I'll do a resection and a colonoscopy within 6 months.
Good, thank you. And there is a question to you, Dr. Sundeep. How the pre-cutting EMR perform? What is pre-cutting EMR? I don't know what.
So we use an APC probe to touch the edge where the lesion has a circumferential margin. We go about a 5 to 10 millimeter away from it and make a circumferential spots all over. This is not as pre-cutting, but this is called as marking. Some people use APC probe is the most commonly used thing, but some people also use a needle that they use for resection as and touch all over around it.
This is an important point about how you treat the margin, because really we trust our colleagues endoscopists, and when we discuss this problem during the MDT, we, as I mentioned before, we always ask them, has the polyp come out completely? If they say yes, we trust them, and we are quite relaxed in this respect.
Thank you. I think I'll look at the survey. I think in the survey, people are divided. Can you see the results of the survey?
Yeah.
I am sharing the results. So what do you think that in a 45-year-old man presenting with rectal polyp and few polyps in transverse colon, I think a significant number wanted total portocolectomy and ileostomy. Dr. Fabio, are you shocked to?
I'm shocked. Yes, I don't understand the rationale behind this. I would strongly do a rectal polypectomy and surveillance. Absolutely.
I think only 50% is voting for that. I told you yesterday, this is the practice in India. That is something we should change.
Yeah, you simply destroy the life of a patient if you do a total proctocolectomy and ileostomy for a potentially benign lesion or for a very early cancer. Yeah.
So I think the strong message from this panel is that I think everybody will agree, if there is a single polyp which is harboring malignancy and few other polyps, don't try to do total portocolectomy. You try to remove polyps and try to observe the patient. Dr. Sundeep, am I right?
Dr. Chandramohan, I would like to ask, is the audience mainly surgeons, or do we have a mix of endoscopists and surgeons?
I think this has everybody. Even there may be majority will be surgeons, but we have oncologists as well as endoscopists. Medical gastroenterologists also there.
I think we need to have more of interspecialty meeting like this, which will educate each of us, because now I learned so many things from Fabio and Tracy and discussion with all of you that we have to change our view and keep up with the times. Yeah,
I think the main issue is the people not venturing into such a hard task in medical gastroenterology. So if you, it's a very hard task and nobody, it's painstaking and only few people are doing that. Because of that, the majority of the things are managed by surgeons. That is why you are getting this kind of answers. And again, the threshold of doing a genetic counseling is very. Can you comment on the second question? The patient with a few polyps had a family member who had a cancer at 65 years age. Mind you, this patient had only few polyps and family history of fasciculity having cancer at 65 years. So would you recommend a genetic counseling according to UK guidelines?
No, we wouldn't.
Yeah. So I think the there is also almost 40% wanted a genetic counseling in this patient. They are also doing an overkill. And the third question regarding the complete polypectomy in a 50-year-old female, cancer was diagnosed. I think majority wanted, okay, they won't go ahead with a total colectomy. That's good. And next question is, what will you do for a 60-year-old patient with index T3 cancer and and a few other polyps? So again, they wanted some kind of surveillance, not surveillance, some kind of colectomies. So 20% wanted total colectomy, and 40% wanted a sigmoid and left colectomy and remove the remaining polyps. And 40% is a divided school, again a bit aggressive in doing colectomies.
Yeah, I answered to this question already before. So I would try to remove, now if you want, the tricky question is, don't biopsy the cancer and then do the polypectomy. Otherwise you can seed cancer cells and cause metacronous cancer.
Oh, great. Yeah.
But Sundeep may help in this, because there is some evidence about but I would try to remove the polyps that are away from the cancer first, maybe leave the polyp close to the cancer there, and then this patient anyway will have a colonoscopy after 1 year, so you can come back later and remove these tiny polyps, and a tiny polyps will not become a cancer after 1 year. And I don't see absolutely any indication in doing a total colectomy.
Yeah, I agree with you.
Thank you. Anything else? I think it's a wonderful session, and we are getting a lot of ideas by sharing knowledge of these specialties. And there are a few questions as well. Okay, I think one of the issues is the marking. Marking, how can you do mark? Can you use India ink, Dr. Sundeep? How to mark the lesions?
So if mark as a tattoo or mark before resection?
Yeah, do we need to mark with intending in all cases? I think he's asking before resection. Before resection.
Ask for Fabio what they do. What do they do in UK? Because that's where they do it more.
So if I understand well the question, if it is about the tattoo before a resection, this must be done always distally. Okay, we never mark cancer of the cecum because clearly they are there, and we never, absolutely never, mark rectal lesion, because if you do a tattoo in the rectum and beside you induce a degree of fibrosis that may be misinterpreted by the MRI, but you can cause also lymph node enlargement into the mesorectum, which again can be misinterpreted by MRI as metastatic lymph nodes. So our practice that we never tattoo lesion in the rectum, or even in the distal sigmoid. So sometimes when there is a distal sigmoid lesion, that's the only exception when we mark proximally.
Thank you, Dr. Fabio. So anything else? Dr. Dilip, can you make some comments? Because I think there are certain areas that is raining heavily in Kerala, and the few people have lost connection. Dr. Dilip?
Yeah, Chandramohan.
Yeah, we need some concluding remarks.
No comments. I joined late. I didn't hear that.
Yeah, you are supposed to say vote of thanks and conclude the session.
Yeah. So, Chandramohan, you can conclude the session.
Okay, I think it's a fantastic thing. I think we should do some kind of meetings, and I really thank Dr. Fabio and Dr. Sundeep and Dr. Tracy for your amazing contribution, and thank you very much. All the other participants, delegates, I really appreciate it. We have nearly 100 people attend this meeting. Thank you very much. Have a nice day.
Thank you.
Thank you.
Thank you.